I'm Jan Basile, and I'm speaking with Dr. Blase Carabello about best practices for treating valvular stenosis. Blase, when should I recommend valve replacement or repair for my asymptomatic patient with valve disease?
So, first of all, in terms of repairing valves, the only valve that you can reliably repair is the mitral valve. In this country today, most of our patients have myxomatous degeneration as opposed to rheumatic disease, and it's a reparable valve, and that's the big difference between aortic and mitral valves. You can leave the operating room with your own repaired valve in the case of the mitral regurgitation. In aortic disease, you're going to have a prosthesis and all the risks of a prosthesis. So you can recommend surgery much earlier for the patient with severe mitral regurgitation than you might with aortic regurgitation or aortic stenosis. Bottom line is, if you're pretty certain you can repair this valve, or you and your surgeon can get the valve repaired, in case of mitral valve prolapse and severe disease, it's a 2A recommendation from the guidelines. That is, most people would vote to do it, even though the patient is asymptomatic and has perfectly normal LV function. Go ahead and do it now. It's much like what I call the ASD analogy. If you had a patient with atrial septal defect, we don't wait for stuff to happen. You just go and get it fixed because the patient is free of a prosthetic device, is not going to be on warfarin or any other anticoagulant, and they're done. The disease is cured. It's fixed. The caveat is the average number of mitral valve operations done by the average surgeon in this country last year was 5. You might be able to win the Masters if you played every 10 weeks, but probably not. So you're going to practice this idea of early surgery on the mitral valve in context with a surgeon who is very practiced at fixing that valve.
Very good. Now, recently we've been reading about transcatheter valve replacement. How is that going to affect my practice?
So the valve, the Edwards Sapien valve, was approved by the FDA just a day and a half ago. And it will be released, limited to the market in a short period of time. It has been approved for inoperable patients. So in terms of your practice, it's got to be symptomatic, severe aortic stenosis, and your patient's been turned down by 2 surgeons for an aortic valve replacement, presumably due to other comorbidities. By far and away, the most common one is chronic obstructive airways disease. So, but this patient would die in 6 months now, and your patient would die in 6 months. But the ability to replace this valve percutaneously may give them not only extra years of life, but extra years of high quality life, which of course is the goal. But that's how it's going to affect your practice.
And when is it okay to ignore symptoms in patients with valvular heart disease?
Never.
Never.
Symptoms are, you can measure stuff. You can measure a BNP, you can measure a wedge pressure, you can measure the ejection fraction, you can measure things. But symptoms are unique. They're an amalgamation of systolic function and diastolic function and the severity of the disease, coronary blood flow compliances, and a whole bunch of things that we can't measure. So once the patient with valvular heart disease develops symptoms, if you can be confident that those symptoms are due to the valve, it is an inflection point in the natural history of that disease, and the patient's going downhill from there. So anybody that has symptoms from valve disease should get that valve repaired or replaced then. Not wait, not mess around with it, not mess with medications and seeing if you can make them better. If they're candidates for surgery or another way of fixing the disease, it ought to be fixed right now. So symptoms are bad.
And just for the primary care doc out there, are there any medicines? A couple of years ago, there was a New England Journal article in AI with a calcium channel blocker.
Right.
And recently there were some statin trials trying to prevent valvular heart disease?
So we'll take them in sequence. In 1994, Sconomilio and his friends, colleagues, randomized patients with severe aortic regurgitation and no symptoms and normal function to either receive nifedipine or what they used as a pseudo-placebo, digoxin. And the data appeared that it looked like the nifedipine forestalled the need for valve surgery by about 2 years. We were so happy. You may know there have been over 500,000 patients randomized to different trials in cardiology, and there are over 6,000 trials. Only 15 of them pertain to valvular heart disease. And I was a member of the guideline writing committee in '98. We were so happy that we had a randomized trial. We did a couple of cartwheels and recommended as a 1 to put your patient on with aortic regurgitation on a vasodilator, presumably nifedipine. 11 years later, along comes Evangelista and his colleagues from Spain, takes exactly the same dose of nifedipine, this time uses a real placebo instead of digoxin, and had a third arm, enalapril. Nifedipine did nothing to delay the onset of the need for surgery, and it looked like enalapril maybe actually was worse. It came within about a patient of 2 of being statistically worse than placebo. The difference between the Evangelista study and the Sconomilio study is blood pressure, I think. So the blood pressure, systolic pressure, was 30 millimeters higher in the Sconomilio trial than in the Evangelista trial. And I think those guys were just treating hypertension, which of course is bad for you. Hypertension is always bad for you, whether you have valvular heart disease or not. And so I think that's why they did better. So we went from a 1 in '98 to a 2B in 2006 because now the data were conflicted. And so I think it's up to whatever you want to do. So as far as aortic regurgitation, if your patient has hypertension, you should treat it. If they have heart failure, you should treat it, hopefully with a valve replacement. If they're not candidates for a valve replacement, then vasodilators seem reasonable. Otherwise, So, when you and I were kids, we called aortic stenosis degenerative calcific disease, meaning we didn't know what the hell was going on. 1992, Catherine Otto and her colleagues looked at a bunch of patients who died not from aortic stenosis, but from automobile accidents and those sorts of things. It gave them the opportunity to look at very early disease. And when they looked at the valve in these people, the plaques resembled in every way the plaque of atherosclerosis, coronary disease. And so it made some sense. Well, if this is atherosclerosis, why not use statins, which have been so effective? They didn't work. The SEAS trial is the largest randomized trial in all valvular disease. 873 patients randomized to either Vytorin, which is a combination of simvastatin and ezetimibe, placebo. The Vytorin lowered the LDLs from 135 to 55 and didn't make a dent in the progression of aortic stenosis. Now, those folks had a valve area of about 1.25. So along comes the Astronomer trial, which said, well, maybe we should try this in earlier disease. And the average valve area in Astronomer, which used rosuvastatin, was 1.5. Still no difference. And I think the difference is coronary disease kills from plaque rupture. And it's likely that the statins are reducing inflammation and helping to stabilize plaques, and that's why they make you live longer. Whereas in aortic stenosis, the disease is from the accrual of all of this stuff. Let's not throw the baby out with the bathwater. 9% of patients with aortic stenosis have not just calcium in the valve, but lamellar bone, true bone. And so that if we could figure out the pathways that are leading into the calcification and bone formation, we still might be able to prevent the progression of the disease. And I think we can. It's just not going to be with statins.
Right. Good. So just summarize a couple of key points you want docs to know out there about valvular heart disease.
So if you're, first of all, even the very best of us are not that great with murmurs. Even the best diagnostician is wrong about 20% of the time. So that anytime you have a heart murmur that doesn't go away with Valsalva, get an echo. Then, using the criteria for valve severity, if your patient has severe disease, ask 2 questions. Does my patient have symptoms? And are there signs that the disease is starting to impact or impair the left or right ventricle? Now, patients deny symptoms. Therefore, I think it's a good idea, and I do it for virtually every asymptomatic patient. I put them up on a treadmill. Are they truly asymptomatic? If they're truly asymptomatic, I'm reassured that they're okay. The patient who says that he or she is asymptomatic is going to exercise anyway. Better you do it in front of you, where you can see how they perform. If they're still asymptomatic and there's no impairment, I think it's safe to watch for a while longer, every 6 months or a year. In the case of mitral regurgitation due to mitral valve prolapse, practicing in an environment where you can be almost certain the valve can be repaired, repair it now. Valve repair for the mitral valve is, in every study that's ever looked at it, far superior to mitral valve replacement. So that's the next point. In the case of the mitral valve, in non-rheumatic disease, which is what we have almost exclusively here in the United States, get that valve repaired. And then hold on to your pants, because percutaneous devices are going to come and they're going to get developed. And while you and I are sitting here having this conversation, there are engineers back at Edwards and back at Medtronic trying to make those valves and those devices better. And so it is going to open up. This Edwards valve is a wonderful advance, but it's just the beginning. And it's going to change our practices fairly dramatically over the next decade.
Well, thank you very much for being with us at the annual Southern Medical Association meeting.
My pleasure.